Short case.
Yeah.
So my patient, a 57-year-old male, homeless beggar, a case of traumatic, healed, mature, right below knee amputation with a stump length of 25 centimeter, who currently the help of bilateral axillary crutches and currently is not having any complaints. Patient has been admitted for the forearm injury.
What is on the right side? How is he using auxiliary crutches with the hand which is handicapped? Huh?
Sir, he has a trauma 10 days back.
10 days.
Yes. Before that, he used the help of bilateral auxiliary crutches.
Bilateral auxiliary crutches. So, what is the length of the crutch he was using? How do you tell the patient how much crutch length has to be there?
Sir, we calculated from the axillary fold till the level of heel, 15 centimeter from the lateral malleolar.
Who told you all this? From the axillary fold he wants to take, right into the axilla.
Anyone knows from the audience who can stand up and tell us how to measure the length of the crutch?
Now that also I have told you. I have not told? Okay, it has to be 2 finger breadths below the axilla so that he doesn't get a crutch paralysis. So 2 fingers. And what is the grip? How will you hold the grip? The handle?
Sir, the elbow has to be in 30 degrees of
So
flexion.
how do you manage that?
So the handle should be at the level of greater trochanter so that the elbow
Greater trochanter.
at the level of greater trochanter so that the elbow will be in 30 degrees of flexion.
Now, who told you all these things? Has anybody told ऐसा ही कुछ मन में आ रहा है ऐसा? You're putting it in the axilla, greater trochanter. No. If it's an auxiliary crutch, if it's a walker, if it's a stick, the level comes at the rest level, the handle, so that when he does that, he has 30 degrees of flexion. Wrist level, wrist for all 3. Now get that trochanter out of your mind, please. And 2 finger breadths below the axilla. That is just for your knowledge. Okay?
Go ahead.
Chalo.
Patient had a history of road traffic accident and polytrauma 22 years back, for which he was operated on the same day. And according to patient, some screws was put on the right lower limb, and the limb was amputated on the same day, and skin grafting was done from the anterior aspect of the thigh. Later, patient the dressing was done for around 5 to 6 months, and wound healed on its own. Patient had a history of trauma to history of assault 10 days back. He sustained a trauma to right forearm, for which he is admitted.
Okay, so we are talking about the amputation stump, that thing now.
Yes.
Now
Sir,
you are presenting stump or this
Stump.
Stump.
you
No,
are presenting stump. So your short case is stump. Now start about the stump.
Yes.
Don't talk about the upper lip.
On examination, the stump is conical in shape with approximate length of 20 to 25 centimeter. It is healed with secondary intention. There is a
Don't give a range, na? You have measured it, right? So give
No.
one number.
It is 25 centimeter from the medial joint line. It is healed with secondary intention. There is a hypopigmented, the skin is hypopigmented and scarred over the end of the stump. There is a wasting of 4 centimeter in the thigh region and 2 centimeter in the calf region on the affected side. There is no localization of temperature. There is tenderness over the bony ends, which are irregular.
You talk about only SSS. Size, shape, surface, skin, strength. You go ahead by this. So first you was the size. The shape you did not set. It was conical.
Conical.
Okay. The scar placement. You go like this. Scar is healed second now. Then
Is that
skin.
healed?
It is healed with secondary intention.
Okay. Now skin, whether it is mobile over the stump or not.
It is not mobile over this. The skin is
Yes,
not mobile. It is-
fake, adherent. Okay. Any discharge, sinus,
There are no discharge, no sinuses over the
strength. Strength means
Sir, there is he is able to do active SLR. There is a flexion deformity of 20 degree with further flexion possible up to 120 degree without any pain and crepitus
Very
in the
good.
right knee joint.
any stretch, stiffness in the
There's-
proximal joint.
There is no stiffness in the proximal
So you
joint.
talk with their ideal stump having multiple SSS. Correct?
Yes.
Okay.
Does he have a flexion deformity at the hip?
No, ma'am.
Okay. So there is no deformity.
At the knee, he has a 20 degree flexion deformity.
Oh, he's got show me the amputation stump. Ask him to lie it straight.
Oh God. See the
Aiste.
see the
Gloves डालो doctor.
yes.
Was he wearing a prosthesis?
Sir, he was prescribed a prosthesis 3 years back, but he could not walk with the prosthesis. He was still using the auxiliary crutches because he has developed the gait over 20 years. So he discarded the prosthesis and he started again walking with the auxiliary crutches.
Oh, acha. Stump. Show me the FFD.
Full extension is possible or not?
आप सीधा सो जाओ.
काका सरळ झोपायच्या
सीधा सो जाओ.
सीधा
सरळ झोपा
नाही सरळ बघा, पाठीवर झोपा पाठीवर.
झोपायचं
येस.
बरोबर पाय सरळ करा
उजवा पाय सरळ करा. शो मी द डिफॉर्मिटी.
no you was telling there is no deformity
नाही, he said 30. He said 30. He said. How much he has got?
He said 20 degree.
20 degree flexion deformity, no extension possible.
And further flexion
Further flexion up to 120 degrees.
that he has.
Yes.
Okay.
Dila sir.
Amodo. Agreed. So now the other day I was telling you about the most important is the flexion deformity of the knee. Once the patient has got a flexion deformity, he cannot lock. He has to press the knee down. So what is the first thing? Flexion deformity. That is very important. No prosthesis can be fitted unless the deformity is corrected. Out of question. Now go for, as Dr. Khandelwal said, stump.
So the stump is conical in shape, irregular.
Yes, you are saying na?
So it is irregular in shape.
Yes.
With healed with secondary intention. With
Secondary intention.
with the
Then-
hypopigmented scar, skin is not movable over the end of the stump. The muscle coverage appears to be inadequate with bone easily palpable. There is tenderness over the end of the stump.
Good. Yes.
Then, sir, there is wasting or
So he's got that bone which is protruding out, that hypopigmentation, the scar is stuck,
Yes.
and it is immobile. Important. And he has got a FFD
Yes.
of the knee. You were asking? Acha. Yes, good. Very good. So all this is pointing towards what? That the stump is good or not good?
it is not an ideal stump.
Yes, not ideal.
Why?
Why?
Sir, for an ideal stump, there should be adequate muscle coverage.
No, that's here. Here, muscles cover. Here, what is important part? You just tell important. It is a deformity is there. That is the important part. And if the deformity is there, you cannot proceed for the prosthetic fittings.
Yes.
Okay.
Yes.
So unless it is not ideal stumps, length part, shape part, sensation part is separate part. But here the deformity is there. So it is non-ideal stump.
That's what I said the other day on Friday. No knee can be good if there's even if your TKR, you give a FFT means finished, it's gone. So there also in a TKR, in OA or in the amputation stump, knee deformity in flexion is a gone case. That must be corrected.
Was it
That
a
is what he
planned
said.
amputation or it was an emergency amputation? What was it?
So it was a traumatic amputation. He was operated on the same day,
Huh.
and it
He
was
came with an amputation.
sir. It was a. He was saying it completely fell off almost.
Okay.
Rail accident or RTA?
RTS, road traffic accident.
So that means it will be
So-
type 3.
So they closed.
Gustilo Anderson.
So they closed on day one.
3 C.
Ah,
Gustilo
C. bolo.
Sir, they closed on day one.
Sir, the patient is saying that a graft, the skin was taken from anterior aspect of thigh and it was applied, but he had to get.
So
dressing
now
over-
enumerate the things which are non-ideal for this. It is not an ideal amputation stump. So enumerate the things which are non-ideal and what could have been done on day one. You would have done.
Sir, I would.
So
do-
skin graft is good for amputation stump?
No, sir.
No, because it is not going to take
No,
weight.
no, instead of asking good or bad, is it advisable or non-advisable? Or doing this practice, covering the stump by the graft or the flip, is it advisable or is it wrong practice?
It is not advisable. First, we do go for a guillotine type of amputation.
Yes,
and
that
later
is the
after-
ideal practice. You have to
later
go
after-
for open amputation, and
You
once
have to-
your infection part is controlled, then go for the closer part.
Yes.
This is the ideally we have to do.
You have
On
to
the
send a
first day
culture
you
swab.
are going for the closer, it is not acceptable. Second things, some plastic people advise always flap coverage over the stump, which is a wrong practice and not acceptable because they do not have the sentinel. It is very difficult for prosthetic fitting. If you apply prosthetic, then possibilities of the skin erosion and problems arises. So it is not advised. So it was not done. Huh?
Yes.
So skin grafting over the stump. So there is a hypopigmentation, the scar is stuck, the bone is coming out. So most inadequate and most non-ideal for prosthesis.
Why
So
there
what
is
you would do?
hypopigmentation?
Because the skin has been thinned out, because of which the bone is compressing over the skin, and it is
Sensation?
sensations are intense, sir.
No,
Excuse me.
No,
Now skin grafting was done. Now you said where it was done.
Sir, it was over the stump side.
So therefore now he's asking why there is hypopigmentation. That means they did a skin graft, and the skin graft, the superficial is gone. Superficial aspect of skin graft is also the melanin has gone with that. So that is how it is got hypopigmentation over there.
One thing I am telling you, skin over as far as the flap or the skin coverage, in the upper limb it is advisable, but in lower limb it is not advisable any grafting or flap coverage. So please keep it. Here, whenever you are feeling the stump size is not sufficient, then you can think about this. But if there is a sufficient size of the stump is available, instead of going the grafting, you can go for the shortening, and that is always better.
Yes.
Now, how would you proceed for making the ideal stump or the good stump? Here,
From this case,
particular.
correct. Now tell.
Sir, if I want to revise, I would do it at the ideal level, which is around 12 to 15 centimeter, where there is adequate muscle coverage. I would take a longer posterior flap to cover it
No,
entirely.
first you go for the flap lower portion, or you have to correct the deformity first.
What he told you first.
Sir, first I will correct the deformity.
Ah.
Patient is-
How would you correct the deformity?
The cause most probably.
No,
would
what
be-
are the options are there? Whether you put a skin traction, skeletal traction, or you will go for the illegal or ring correction. How would you go?
Sir, because since it is a long standing deformity, I would go for a gradual correction. With the
How?
How many years deformity?
22 years.
So how you can do?
Why did the flexion deformity develop in the first place?
What he is using for ambulation?
He is using crutches.
So obviously he's not using prosthesis, na?
Yes.
So that obviously because of the persistent flexions, it gone in the deformed. Now, question is that now if patient is telling, sir, I want to walk with the prosthesis, then you have to do something. Now, what you will do first, you correct the deformity, then how would you go for the deformity correction?
I would do a gradual correction since it is a
Gradual correction means you would go for the rings.
yes, sir. Gradual correction with the help of laser or rings. laser of apparatus, and after correction of
Is it
the-
advisable directly go for the skin ring correction? Now you again failed. If I am in place of you, then I will go for others. I first put a skeletal traction. That is my fault. Practical point is this, and if I feel no, correction is not possible, then I will think about the ring. Directly going for the ring and gradual correction, you are trying to teach your teachers.
Okay. So skeletal traction, good. Huh? That if not possible, as he says, ring.
Ring.
Okay.
That's all right. Huh?
That's good.
Now, second was the deformity correction. You go for the stump management part. Now, what will be the position of the scar and how? What are the part of the stump corrections? 1, 2, 3.
So the length of the stump,
The on length is good. Stump is all right.
Length
As
is
much as
good.
length you
the skin
can.
coverage, muscle
Ah.
coverage, and the bony resection.
Bony resection. The important part is the placement of the scar. Second thing, division or the removal of the anterior portion of the tibia for the better prosthesis fitting. Otherwise, it will hit to the prosthesis.
And a primary scar, you have to give a primary scar. So you will cut the tibia slightly high, maybe 1 inch, you'll get some length over there. And then maybe if you have a
Right.
gastrocnemius, you can put on top of it. Principally, the scar is not good. So first, correction of a FFD and then scar. That's the end of the case. Okay? Okay, good. Chalo. Next.